en Nuevo León. Actualmente es director de oncología y jefe del Departamento de Radioterapia, Hospital Zambrano Elion y Hospital San José Tech Salud. Y como ponente le damos la bienvenida y agradecemos que haya aceptado la invitación y una sincera disculpa por el retraso al doctor Jeffrey Wong, graduado del Johns Hopkins y actualmente codirector de City of Hope. Tiene experiencia amplia en tumores genitourinarios hematológicos, IMRT y técnicas avanzadas como tomoterapia, incluyendo el tema de hoy, irradiación corporal total. Para no demorar más, le doy la palabra al doctor Eric Pérez y al doctor Jeffrey Wong. Adelante.
Muchas gracias, buenas noches. Y una disculpa de nueva cuenta por la demora aquí en la dificultad técnica que tuvimos. Y me prefiero tenemos el honor de tener al doctor Wong de nuestra sesión. Vamos a sacar bastante provecho. Esta es la segunda frecuencia después de que el mes pasado hablamos del mismo tema de radiación corporal total, ahora enfocado en el tema de trasplantes y de hematología. Y sí ahondar un poquito más en la presentación del doctor Wong, que como bien dicen es graduado de Johns Hopkins, de la Universidad de Johns Hopkins. Actualmente es director del Centro de Estudios Diagnósticos y de Vanguardia del Hospital City of Hope, que permite a los médicos encontrar y tratar estas células tumorales. Y es recordar que City of Hope es un centro comprehensive de los fundadores de la NCCN. Las principales áreas de investigación que incluye el trabajo del Dr. Wong son el desarrollo de estrategias para terapias dirigidas y biológicas. ¿Están escuchando? ¿Sí? Y guiada por imágenes. Él durante 25 años dio el departamento de radioterapia del departamento de radioterapia del Hospital City of Hope, y a través de su dirección tuvo un incremento bastante trascendental, y ahora pues es un departamento que cuenta con últimas tecnologías en tratamiento de técnicas especializadas, sobre todo en tomoterapia. Él fue pionero, doctor Wong, del uso de esta forma dirigida de radioterapia dirigida hacia la médula ósea, y el primer caso que tiene reportado de tratamiento fue en el 2005, junto con todo el equipo de su departamento de radioterapia. Desde el 2012 están practicando técnicas de irradiación corporal total, de TBI, con IMRT, también de irradiación nodal total y también medular total. Creo que no terminaríamos de decir todo su currículum, todo su expertise, y damos pie a su presentación, que va a ser bastante interesante, y de nueva cuenta muy agradecido. Vamos a tener traducción en simultáneo. Muchas gracias y adelante. Dr. Wong, thank you.
Thank you very much. It's great to be here, and it's nice to see you again, Dr. Perez. Thank you so much for the invitation, and thank you, Samara, for also for inviting me. Shall I share screen now?
Yes, please.
Okay. Still disabled? Okay, thank you. Should do it. Can you see the screen?
Yeah, doctor. Yes.
All right. I don't know how to get rid of the bar up there, but we'll just go ahead. Okay. Again, thank you. What I'll do is go over our experience with total marrow irradiation, a more targeted form of total body irradiation. And we feel this is a way to expand the role of radiation therapy in patients undergoing hematopoietic cell transplantation or bone marrow transplantation. These are my disclosures. For those of you that aren't too familiar with City of Hope, we're located in Los Angeles. It's an institution that's over 100 years old. We have centers throughout the country. We're one of 52 National Cancer Institute designated comprehensive cancer centers. We're a founding member of the NCCN. This shows the radiation oncology program. It's again a big program with sites throughout Southern California as well as across the country. Let me see what I can do to help minimize this. Okay, and for total marrow irradiation, almost all the patients are treated with tomotherapy, but some also by VMAT/TrueBeam. We're very fortunate to have a very large and established bone marrow transplant program. It's been established in 1975. So it's one of the largest in the country. We transplant over 850 patients per year. Almost all are myeloablative. Half of those patients are allogeneic transplanted. This is the population where TMI is delivered as well as TBI. We performed over 1,000 allo transplants over a 3-year period. Every year, there's about 200 patients that receive TBI or total marrow irradiation. Just last year, 163 TBI, 53 TMI. See a picture of our transplant center here. At our institution, we deliver the treatment in the standing position as shown here. There are 50% lung transmission blocks that are used. It's in an extended SSD, which is fairly typical. Therefore, the dose rate, because of that, is usually at 20 centigrade per minute or less. We fractionate our dose, as most places do. We adopted the Memorial Sloan Kettering approach from the 1970s, 1.2 centigrade per fraction up to 13.28. We boost the chest wall and
okay. Sí. Volviendo a lo mismo, sí. Exactamente. Sí. Sí.
Sorry.
Todo muy bien.
We pay.
¿Listos?
Are we okay now? Okay, sounds good. TBI is, as many know, is still a very important part of the conditioning regimens for patients undergoing transplant. You already know there's anti-leukemia effects, immunosuppressive effects are needed for allogeneic transplant. In addition, it can reach sanctuary sites. There are some randomized trials that continue to demonstrate that the TBI regimens are superior. For example, here's a meta-analysis of about 5 trials showing that some of the trials are showing TBI is superior. In a recent randomized trial in ALL, they randomized between a TBI arm and a chemo-only arm. It showed a superior outcome for the TBI arm. And so TBI, again, is very much an important part of the conditioning regimen. However, there are challenges to TBI. There are side effects, of course, that are acute and late because the same dose is delivered throughout the entire body. As a result, older patients above 55 to 60 years old are unable to tolerate TBI. And many patients in this age group or older have leukemia, for example. There's an inability to add TBI to reduced intensity chemotherapy regimens. People have tried and are unable to do that in adults. And we would like to dose escalate to improve outcomes, but the people have tried with standard TBI, and that's not possible because of toxicities. So a more targeted and organ-sparing form of TBI was needed. This is an example from the Seattle group, Fred Hutchinson, that randomized in a phase 2 trial, AML in first remission between 12 gray and 15.75 gray. These patients got cyclophosphamide, a very common regimen. This is mature follow-up, 7.5 years. What they found was that there was a reduced relapse rate with the higher dose. Most of that effect was seen within the first 2 to 3 years. And of note, once you got past this point, there were very durable remissions with a plateau years out. However, that same higher dose resulted in an increase in toxicities and non-relapse mortality rate. Most of those things occurred within the first 6 months after the transplant. Those toxicities were primarily increase in hepatic and renal grade 3 toxicities. There was also increase in acute GVHD or graft versus host disease, as well as increase in mucositis. And what's interesting here is that they found these differences with just 35, 34, 37 patients per arm. It strongly suggests that we're on the relatively steep part of the dose toxicity dose response curve, where just a modest increase in dose can create some measurable changes in relapse rates as well as mortality rates. So how can we improve upon that? Another thing I should mention is there's lots of data that show that there's a dose toxicity relationship for many of the end organs. This is all from the TBI literature. There are many examples. I happen to just put the examples that we published showing a dose toxicity relationship between with lung toxicity, renal, and cataract formation. So of course, if we could reduce the dose, we can potentially reduce the toxicities. Our investment in total marrow irradiation started with this video that Rock Mackey presented at a meeting at UC San Francisco in 1999. I happened to be there, and this was an example for mesothelioma. The technology had yet to be approved by the FDA, but he was demonstrating a concept that immediately interested us. We thought this could be a possible way to spare lung for patients undergoing radiation therapy and bone marrow transplant. So we flew out to TomoTherapy in 2001. We introduced the concept, and we began to work with them to develop a simulation of total marrow irradiation. You can see the videos here that were developed early on in 2001, 2002. We were able to do plan comparisons. This is again before we treated the first patient. You see here on the graph from this patient, we created several plans: TBI 12 gray, TMI 20 gray, TMI 12 gray. Target region is bone in this case. You can see we could escalate the TMI dose up to 20 gray without, and still be below that of the organ doses for TBI 12 gray. What we did see also in this example, as one escalated the dose toward 20 gray TMI, the lung dose volume histograms started to overlap with standard TBI 12 gray. So all our trials to date have capped the dose of escalation to 20 gray. We feel at this level, we may begin to see comparable pneumonitis risk compared to TBI 12 gray. We designed our trials in 2003. I want to point out a very important part of that is to do it with your hematologist. And we installed our first machine in 2004, and in 2005 treated the first patient. There were a lot of questions that were raised before we even treated the first patient, from radiation oncologists, from hematologists, even from TomoTherapy. There were some concerns. These were within our institution, also outside at peer institutions. Was it feasible? Could this technology deliver the color wash you saw in the earlier slide? Will the higher dose rates increase toxicities? TMI doses on these units are in the 70 to 200 centigrade per minute. Will relapse rates increase because of multi-organ sparing or because of underdosing of circulating leukemia cells? These are the three main questions up here, and you may be asked this also as you begin your programs. Can toxicities be reduced with organ sparing? Is dose escalation feasible without increasing toxicities? It was clear from the beginning we needed to address these questions in a very formal way through prospective trials. And we needed a two-stage approach. We could not immediately go into this population. That's the standard TBI population. We couldn't just go into that population because TBI already had an established role. We went into this population, the population that was had poor outcomes. They had no standard of care transplant options. TBI is not used. And this outcome or this group has a survival rate of about 20% or less. And then once we established the role for TMI in this population, we could eventually move to the standard population. These are patients in remission, and look at it as a replacement for TBI. So again, it was not set up or started as a replacement for standard TBI. We wanted to expand the use of radiation therapy to a new population of patients. These were patients with relapse or refractory disease, and as well as older patients, as I mentioned a bit earlier, older than age 60, with comorbidities who cannot tolerate myeloablative TBI. We wanted to reduce toxicities, dose escalate to improve outcomes without increasing toxicities. And we've done multiple trials to date. Over 550 patients have been treated. First patient treated in June of 2005. 8 trials completed, 5 ongoing, most on tomotherapy, some on variant VMAT. People have also used Electa units to treat patients with TMI. Our initial trial was in multiple myeloma, but since then, we and most centers involved in this area have concentrated on acute leukemia. We've concentrated initially on older patients with relapse refractory disease. And here our focus is to add 12-grade TMLI to an established reduced intensity chemotherapy regimen. The second population, younger patients with active disease. We wanted to dose escalate in this younger patient, and we've combined that with cyclophosphamide and etoposide. I'll share with you also that since once we started in this population, we started to look at haploidentical transplant patients, and then our most recent efforts are the patients in complete remission. So just for definition of terms, again, these are the organs we spare. The first trials treated just bone and bone marrow. These were our myeloma trials, autologous transplant. We termed this TMI, or total marrow irradiation. We escalated up to 18 gray. Here's a color wash of that particular patient population. As we went into allogeneic transplants for acute leukemia, we added the lymph nodes and spleen for the immunosuppression that's needed in allo transplants. We use the term TMLI. We've escalated in younger patients up to 20 gray. This should be updated. In older patients, we're up to about 16 gray. Here's a color wash of that dose distribution. In younger patients, we've added the liver and brain. Again, 20 gray, liver and brain, we've kept it 12 gray. And here's a color wash of that distribution. From the beginning, we did not target the mandible. The reason is we wanted to keep the oral mucositis at a low level. We are an institution that chose to do TBI etoposide that's associated with more mucositis. So our hematologists wanted to not do what we could to reduce the mucositis risks. We kept the dose fractionation and comparable to standard TBI. We didn't want to introduce another variable given all the questions that were asked from the beginning. So let me just briefly go over the first trial. This is in multiple myeloma. This is a tandem autologous transplant trial with melphalan. And this trial is completed. The reason for doing this trial, others have tried to add just regular TBI onto melphalan that's used as part of the auto transplant for myeloma. We felt that perhaps TMI could be added to melphalan. It also gave us a chance to look at the toxicities of TMI alone without concurrent chemotherapy. These were patients with stage 1 through 3 multiple myeloma who were responding to treatment. They first underwent an auto transplant with melphalan. 6 to 10 weeks later, a transplant with TMI as the conditioning regimen. These were the dose levels that we escalated through, and then they went on to maintenance therapy. It was well tolerated. For the first 3 dose levels, patients didn't really want to be in the hospital. There were very little grade 3 toxicities. Once we hit to 16 gray, we had grade 3 nausea and vomiting. We modified our emesis or nausea regimen. We escalated further to 18 gray. Here we hit dose-limiting toxicities. 2 patients had enteritis or colitis. 1 had pneumonitis that reversed quickly with steroids, and 1 had congestive heart failure or hypotension that reversed with pressors. They felt this may be more related to engraftment syndrome. What was important about this trial, it really was the first effort to show that delivery is feasible, toxicities are reduced because of organ sparing. The increased dose rate did not at that time seem to increase toxicities, and we continue to see a lack of dose rate effect. Dose escalation was feasible. I think this is the most important. It convinced more of our hematologists to further evaluate TMI and TMLI in trials. Just to point out, this trial is now very mature. We recently published on a median follow-up period of over 12 years. And you can see there's a plateau of patients out here that have survived over 10 years out. There are other efforts that have been published on myeloma. The group EBMT, this is the group in Poland. They've also done a tandem trial with melphalan and TMI, no dose escalation, but 4 gray per fraction, very interesting. These groups have combined concomitant a TMI with melphalan and showed feasibility. The group at Ottawa has used TMI alone to salvage patients who have relapsed after initial auto transplant. And we're going to present at ASTRO our allogeneic transplant results using TMI and fludarabine and melphalan. I think you may know that in myeloma, transplants aren't, at least radiation regimens for transplant in myeloma have sort of fallen out of favor or interest. So really now most of the field has shifted or expanded the use of TMI and TMLI in acute leukemia. So let me go through those studies, just provide somewhat of an overview. So let me go through the patient population that are older with TMLI added to a reduced intensity chemotherapy regimen in patients with active disease. So reduced intensity chemotherapy regimens are for patients who are older, who cannot tolerate full intensity regimens. Sometimes the TBI dose is lower, or the chemotherapy regimen is less intense, lower doses, better tolerated, used frequently in patients who are older. Keep in mind, AML, the median age is 68 years old. But because it's less intensive, there's a potential for higher recurrence rates. This was demonstrated, for example, in a phase 3 randomized trial comparing full or high intensity versus reduced intensity in patients with MDS or AML. Now, these are patients in complete remission. And even in complete remission, low tumor burden going into transplant, the group that had the reduced intensity regimen had an increased relapse rate, and that translated into reduced survival. So this trial was stopped after about 2 or 3 years. The regimen that we piloted at City of Hope in this older population in relapsed refractory disease, they have active disease, and they would normally not get transplanted, was the established reduced intensity regimen of fludarabine melphalan, and we added to that TMLI 12 gray, 1.5 gray BID, brain and testes treated or included if you had ALL. The fludarabine, I want to point out, was given concomitantly with the TMLI. Melphalan then followed. This is a mature study, 61 patients, no standard of care transplant option, older population. In this study, up to age 70, I can tell you that we now go up to age, the oldest I'm aware of is now about 77 that's gone through this regimen successfully. Most were acute leukemia, as you see here. Some had prior transplant. 35 of them had a high risk. You can see they had active disease going into this transplant regimen. However, the results are very encouraging. Again, long follow-up, median follow-up 7.4 years. You can see a plateau basically. Overall survival is 42%, and the 5-year estimated survival, event-free survival, is 41%. This compares very favorably. It's superior to the historical results of 20% or less, as I mentioned earlier. It was well tolerated. Non-relapse mortality rates similar to fludarabine and melphalan at about 30% at the 5-year point. You may be aware that there's a recent study using a radio-labeled antibody to CD45 in the same population in a transplant regimen. They showed a 26% 6-month event-free survival. And it's, obviously this result compares favorably to that. So in summary, for this trial, we can combine 12th grade TMLI on top of fludarabine and melphalan in this older population with advanced disease. Acute toxicities, as shown in this summary table, were comparable to fludarabine melphalan chemotherapy alone. The results in terms of survival are superior with long follow-up. We are now in a dose escalation trial with this regimen. Here is the schema for that. I won't go into any details other than just to show you this ongoing trial. We could not dose escalate if fludarabine was given with TMLI, so we had the fludarabine come in after the TMLI, slightly lower dose, melphalan dose also reduced. As I mentioned earlier, we're currently at the 1600 centigrade dose level in this phase 1 trial. Let me just highlight a few other trials that are in patients who are older or with comorbidities. These 2 trials were trials that looked at patients that had prior allogeneic transplants. So again, cannot tolerate TBI type of regimens, and they showed feasibility with TMLI combined with the fludarabine melphalan backbone. You can see they reached a recommended phase 2 dose of 12 gray in these 2 studies. These are studies that combine TMLI with fludarabine busulfan. It suggests that you may not be able to escalate to as high a dose with this regimen, but they are also expanding, especially this group. They've expanded this trial to now a phase 2 setting. And an interesting trial, only in abstract form so far, from Ohio State, for the patients who are older. Instead of TBI side, they're looking at TMLI side. These are patients in remission. So let me go into the younger patient population. We are, if you recall now, dose escalating in a myeloablative regimen. Again, patients with active disease. Again, the data show that the survival rates are less than 20% in this population. We initially completed and published the phase 1 trial, TMLI, etoposide, cyclophosphamide. Here you see the schema. In almost all our trials, the TMLI precedes the chemotherapy. A younger population, as I mentioned, most matched donors, 51 patients. They had a lot of tumor burden going into trial. You would not transplant these patients normally. Most had over 10% detectable blasts. Half had detectable circulating blasts. We were able to dose escalate to 20 gray with encouraging results. So let me just move forward to the phase 2 trial, which is nearing completion because the results are somewhat similar. Again, same schema. Kind of enlarge the diagram so you can see it a bit better. Here's a color wash. We're covering bone, lymph node, spleen to 20 gray, liver and brain to 12 gray. Again, patients who have relapsed, younger patient population. This was presented at ASTRO. The 57 patients were reported on. You can see once again, lots of tumor burden heading into transplant. 52 of the 57 had blasts in the marrow, a median of 27% blasts in the marrow. Half of the patients had detectable circulating blasts. Here's some dosimetry data, the mean organ doses. Even at 20 gray, we could bring the mean organ doses down to 20 to 51% of the prescribed dose. You can see here that the doses to lung were at 9 gray, kidney 7, heart 7.6 mean gray. We spared the mandible, so the oral cavity is at a lower dose. I will share with you why we now have as a dose constraint 8 gray, because we've seen reduced lung toxicities at 8 gray or less. So the median follow-up, almost 2 years in this report, all engrafted, all achieved complete responses at day 30. The 2-year overall survival is 48%. And the 2-year progression-free survival is 33%. Very, very encouraging, well tolerated with less than a 10% NRM or non-relapse mortality rate. These are deaths after transplant not attributed to disease. So this is a very low figure in this population. And we didn't see any difference between AML or ALL. I do want to mention we're preparing a manuscript with 75 patients. I'm going to just mention that it appears that this number is going to hold. So again, very promising. In summary, briefly, we can combine 20 gray with VP16 and cyclophosphamide. It's an effective regimen in this poor risk population. The outcomes compare favorably to published results. We feel this regimen should be further evaluated in a multi-center trial to essentially validate the results that we're seeing at our center. Similar studies in younger patients. I did want to point out a study we did, which we feel is not feasible to dose escalate. That's combining TMLI with busulfan and VP16. What happened is we saw veno-occlusive disease, which is liver toxicity. We think it's from the combined risks from busulfan and radiation therapy. Dr. Hui, when he was at the University of Minnesota and a group in Japan, have used 3 gray per fraction to escalate TMLI doses to 15 and 18 gray. This group has used 4 to 5 gray fractions, but to a lower dose level. And they compared the results to their historical institutional controls and found that their results with TMI was superior. Same with the group at Lund in Sweden. This is again a mixed type of disease population, but nevertheless, 12 gray TMI combined with Psi or VP16, when they compared the results to their historical TBI group, they felt their results were superior. So all very encouraging results. And if you can sense, if you look at this table, as the trials, the more recent trials have started to be more selective and just include patients who are in complete remission. I hope I'm not going too fast, but let me just share with you the effort of using TMLI in a myeloablative regimen in a haploidentical transplant setting. This work was published recently in Blood Advances. The patients who have a haploidentical donor, meaning they can't find a matched donor, have increased risk of graft versus host disease. The group at Hopkins pioneered the use of post-transplant cyclophosphamide, which has been shown to reduce the GVHD risks. Their original regimen had 2 gray TBI, but we wanted to see if it was feasible to escalate TMLI onto this Hopkins regimen so that we could potentially reduce relapse rates and counterbalance or counter the tendency toward reduced GVL with post-transplant cyclophosphamide. This initial phase 1 trial was 31 patients with high-risk disease. Some had active disease going into the transplant. The TMLI was escalated up to 20 gray. This was to bone and nose. Liver was kept at, and spleen kept at 12 gray. as well as brain. Again, PTCY or post-transplant cyclophosphamide was used for GVHD prophylaxis. Median follow-up almost 2 years. There was 1 grade 3 pulmonary toxicity at 18 gray. Otherwise, no real DLTs up to 20 gray. The non-relapse mortality rate, very encouraging, low in this population. Encouraging 2-year overall survival, 64%, and progression-free survival, 57%. GVHD risks were low. We feel this is very encouraging that you can combine TMLI with post-transplant cyclophosphamide in the haploidentical donor transplant setting. So we are now in a phase 2 trial. What about the older patient with a haploidentical donor? Well, we're also looking at adding TMLI again to fludarabine and melphalan, but adding post-transplant cyclophosphamide. It's harder to dose escalate in the older population, as I mentioned. Right now, we're at 14 gray. There are some very interesting other strategies in the haploidentical donor setting. The group in Perugia is using a Treg and Tcon fusions at certain time points prior to transplant to reduce GVHD without a detrimental effect on GVL. And there's an interesting pilot study just recently published in a pediatric population looking at 8-grade TLI. The regimen is shown here. Finally, let me discuss our recent efforts using TMLI in patients with AML in complete remission. This was recently published in 2022. GVHD, as pointed out, is one of the main causes of mortality after allogeneic transplant. The number one cause of mortality after transplant is relapse. So what this regimen is, it takes elements of the previous trials and combines them together in a standard population that would normally get TBI, AML in first or second remission with a matched donor undergoing allotransplant, and combines TMLI at 20 gray with post-transplant cyclophosphamide. Again, we want to reduce GVHD risks, at the same time reduce relapse rates, and address or counter the reduced GVL risk. And the endpoint for this trial was GVHD-free and relapse-free survival, or what many call GRIFs. And that's defined here. Grade 3 to 4 acute GVHD, chronic GVHD requiring treatment, relapse, or death from any cause. This is the regimen. Radiation-only conditioning regimen, no chemotherapy, 20 gray TMLI, combined with post-transplant cyclophosphamide. It's a very novel regimen. Dr. Stein, this is PI on this trial. The target structures are similar to the earlier trials I mentioned, and dose sparing, again, very similar. The initial phase 1 pilot was 18 patients, younger population, again, in remission. We allowed for that you could not have minimal residual disease in this population. They were matched donors, as mentioned. All patients engrafted. It was well tolerated. No grade 3 or 4 toxicities, no deaths related to the regimen. So that resulted in, with over 2 years follow-up, a low GVHD risk, overall survival 86%, relapse-free survival 83%. The non-relapse mortality rate at 2 years is 0. No deaths, well tolerated. The GRIFs rate is close to 60%. And here's the curve out here. So this is a very promising conditioning regimen, we feel, with low toxicity. The results compare very favorably to our historical controls with TBI, 13.2 gray, and cyclophosphamide, or etoposide. Here we had a 2-year GRIFs rate of 39%. As you recall, the previous slide, 59%. So because of these encouraging results, we are now in a phase 2 trial. I did want to mention one other area. I have an interest in targeted radiopharmaceuticals or theranostics. We have a very established program at City of Hope. So it's natural that we combine these two forms of targeted radiation in the transplant setting and begin to look at feasibility. The rationale for our initial trial, which combines an anti-CD25 labeled with yttrium-90 and TMLI plus fludarabine and melphalan is as follows. I mentioned already our efforts using 12-grade TMLI plus fludarabine and melphalan in older patients. Here's that curve as I shown earlier. However, it is challenging to dose escalate beyond 16 gray in this older population. We and other centers have used radio-labeled antibodies as part of the transplant conditioning regimens. We have used CD20 as well as CD25. Others, as I mentioned, have used CD45 and CD33. For example, here's a CD45 trial I mentioned earlier, med-free survival at only 28% at the 6-month time point. But why not look at combining these two approaches? And the rationale for us for using anti-CD25 antibody is up to 53% of MDS and AML can express CD25. It's expressed primarily by the stem cells. We have experience combining this agent with beam chemotherapy in an autologous transplant setting in lymphoma. And adding radio-labeled antibody to TMLI may help to potentially add additional dose to leukemia cells without increasing toxicities, and it may address some questions related to underdosing of leukemia cells in circulation or in non-target areas. I'm just going to introduce the schema, no results, because the trial is ongoing. This is the TMI fludarabine melphalan I mentioned earlier. We add the radio-labeled antibody a week earlier. It's a phase 1 trial. These are the dose levels. We're able to keep the mean organ doses to this level so that we can add on top of this TMLI organ dose radio-labeled. I did want to mention a few other things that we feel are important to our effort. We have a TMI database that was in part designed with colleagues from our TMI consortium group to define what organ dose points to capture, and we do this for every single patient. We capture the entire dose volume histogram for every organ. We link that to the clinical database. We can do dose toxicity analyses. We can also use the data to help facilitate TMI treatment planning. And we're able to define our toxicities more easily and define whether they're related to a certain dose and can define dose constraints going forward. I want to mention that I think many of you are part of the International Bone Marrow Transplant Registry. We have worked with them to add, if you're doing IMRT-based TBI, TMI, or TMLI, you should enter the mean lung, kidney, and other organ doses. We've changed the database so you can enter that. And over time, you'll have thousands of patients to be able to analyze. From our own database, you can see a summary of organ doses. This is for the 12th grade group. This is 108 patients. This is data from 120 patients for the 20 grade group. And you can see the average dose volume histograms for the 20 grade group. You can, again, use this for to speed up planning. I wanted to go over how this database helped to look at long-term toxicity. We looked at our first 142 patients. They received anywhere from 10 to 19 gray, median dose 14 gray, but most received 12 or 16 gray TMI or TMLI. They were entered on a prospective trial, and we collected at 100 days, 6 months, and annually for 8 years. blood tests, pulmonary function tests, ophthalmologic exam, etc., to monitor organ toxicity. The median follow-up is shown here, 5.5 years for the 50 patients that were alive. These are the mean doses to these organs: 7 gray to lung, kidney, 2 gray, 3 gray to lens. The crude incidence of pneumonitis, very low at 0.7%, just 1 out of 142. This is much lower than standard TBI. The mean lung dose of less than 8 gray we found predicted for was significantly associated with a reduction in cumulative incidence of pneumonitis and lung infection at the 2 and 6 year time point. You can see the curves here. The hypothyroid rate was 6%, cataract formation rate 7%. We've seen no significant renal toxicities attributed to the regimen. So we feel that the toxicities related to TMI and TMLI, which we continue to monitor, by the way, but based on the initial analysis, appear to be lower than that for standard TBI. As you recall, people were concerned that there's going to be an increase in relapse rates because of organ sparing. We looked at the extramedullary relapse rates from our first 100 TMI patients that underwent allotransplant. In this report, in 2014, there were 13 patients with relapse, 19 EM relapse sites, and we saw really no dose dependency. You could relapse in a full dose region, close to a full dose region, or in a low dose region. But when you compare this figure with historical figures for standard TBI, it's about the same for EM relapse rates. So to date, we feel that our data shows no increase in relapse rates or EM relapse rates with the use of TMI. And one could argue that TMI in certain circumstances can actually reduce the relapse rates overall. Finally, dose rate effects. There was a lot of concern about whether increasing dose rates would increase toxicities. However, we've seen no problems with engraftment up to 20 gray. The toxicities are lower than what's published for standard TBI, as I just mentioned. And we've been talking to a lot of radiation biologists out there. And when you look at all the data, the dose rate effects are primarily seen at less than 30 centigrade per minute. And they pretty much become non-significant above 50 centigrade per minute. They've shared some data with us that I'd like to go through in this one slide. This is data from a while back. This is an LD50-30 curve on the y-axis versus dose rate. You see dose rate effects in this part of the graph, but once you get above 50 centigrade per minute or so, the dose rate effect goes away. That's not just, this is a mouse model. Here's data from even earlier from sheep, pig, goat, and dog. Same fitted curves. Again, after about 50 centigrade per minute, the dose rate effect goes away for hematopoietic toxicity. In a mouse model, they've transplanted these mice so that they can look at non-hematopoietic lethality. This is a paper with a mouse model. This is dose, percent death. Each curve is a different dose rate. And as you approach higher dose rates, the difference between the curves begins to narrow. You see that in the same model looking at pathologic changes in lung and kidney. So again, if you look at changes in doses in this region, you're going to see changes in toxicities. But as you go higher, it's harder and harder to pick up differences. This seems to be also correlates with what was seen in a trial looking at large data. They only saw a dose rate effect for pneumonitis if it was 6 centigrade per minute or less. And in a review article by Eric Hall, given all the data, they clearly say that there's a large dose rate effect in this range. This is about 16 centigrade per minute. And there's no dose rate effect as you go higher, at least in this range. And this is where TMI and TMLI operates in this range. Just to mention, we and others, you've seen an increased trend now of using IMRT to deliver TBI. I think this would not have happened without the initial TMI trials. There's dosimetric advantages, of course, using IMRT versus standard lung blocking. There's been a very important paper out of Emory that looked at the children oncology group data and found a association with lung dose. And these are patients that receive standard TBI. There was a decrease in survival if the lung dose was over 8 gray. So all of this data in particular are creating change in the COG. Their trials are now allowing or looking at adding as an option the use of IMRT TBI in their patient population. We also consider IMRT TBI for patients that have received prior radiation. It's a good way to avoid a certain area that has been previously irradiated. This is our particular trial, just completed, just showing you the dose schedules that we've utilized. We keep the lung dose below 8 gray. The prescribed dose to the total body needs to be a minimum of 85% of the prescribed dose. Just a little bit about some technical slides. I'm not the physicist, so I'm not going to give you a lot of technical detail. We simulate our patients supine. We use an Accuform molded cushion. We use an S-frame thermoplastic mask, full body backlock. We perform at the time of simulation 3 non-contrast scans, one with quiet breathing, one with inspiration, one with expiration. We do a 4th CT for the legs. We put radiopaque BBs at the junction point. Contouring at our institution is done on the Varian Eclipse system. I've already shared with you all the organs that are contoured. The target structure depends on the protocol. Again, we've excluded the maxilla and mandibulary bones, mandibular bones. The margins at our institution around the target areas have been somewhat customized. We put a 5 to 10 millimeter margin around bones that have a high setup variability, such as shoulder, spinous process, extremities. We contour the skull and ribs separately so that we have a better way to optimize dose to these bone targets while keeping the brain and lung doses at a certain level. Respiratory motion, we correct for that for these organs. And now what used to take 2 weeks, it now takes 1 week from CT sim to start. Actually, it's now down to about 3 days. What really has helped that is our auto segmentation that we've developed. And as you can see, this is a manual segmentation, and you can see good correlation with the auto segmentation. That has really reduced the contouring time down from 6 to 8 hours to down to 2 to 3 hours. For planning, as mentioned, for the TBI, also for TMLI, we want the bone PTB to receive at least 85% of the prescribed dose. We limit the mean lung dose for reasons I've said earlier to 8 gray or less. And we plan based on our lookup tables that we've developed over the years to determine what mean organ doses to plan for. So in summary, on the technical side, it takes 60 minutes to sim, 2 to 3 hours to contour, optimized plans in 2 to 4 hours. You're on the table for treatment for approximately 70 to 90 minutes. So the last few slides are just summary slides. We're coming towards the end. Yes, we're able to integrate TMI and TMLI into either a myeloablative or a reduced intensity conditioning regimen. We feel we can go up to 20 gray if you combine with cyclophosphamide and etoposide. We've seen very encouraging results, as I mentioned. Toxicities are reduced compared to standard TBI. We don't think there's any real high dose rate effects with TMI, and we've seen no increases in toxicities. Organ sparing does not increase relapse rates. We are now in a complete remission population, and we feel this is a very promising regimen of TMLI and post-transplant cyclophosphamide. We feel that the time and effort needed to deliver TMI should be now similar to standard TBI. And what I think is most important in our experience, we work very closely with our hematologists to design the regimens, to design the dose distributions. And I think once they see the power and the potential of this technology, I think they will have some very interesting input into future trials. Just again, an overview, this is our standard population. As mentioned, we could not go into that population initially when we went into the relapse refractory population. We are now dose escalating, but also dose escalating with radiopharmaceuticals. We are in an IMRT TBI phase with regards to TBI delivery. Other centers are also doing this. However, we really feel that TMI eventually will potentially replace TBI, even in the complete remission population. So for future directions, if you have active disease or MRD positive, we feel these patients, TMLI should be evaluated in multi-center trials. In the younger population, dose escalated. In the older population, combined with reduced intensity. And similarly, in the complete remission population, similar strategies should be looked at in single and eventually multi-center trials. And then those that are most promising, perhaps in randomized trials versus standard of care as a potential replacement for standard TBI. I'd like to thank everyone on our team that has made all this possible. There are more people than I could list, but there's a large hematology group and radiation oncology group. These are the core people that meet every week to go over the research trials. We have Zoom meetings with people around the world. This is the core group that meets with them. Special thanks to our dosimetrists and radiation therapists. This is not an easy thing to do. It gets easier and easier as you do more, but I don't think we could have done it without their commitment. This is I wanted to thank also everybody that we're aware of that's interested in this area. This is all the people we've talked to or interacted with over the years. So collectively, I think all of these centers have helped to advance this particular area. So I wanted to thank everyone that has participated in any kind of TMI effort. Here's just a collage of some of the people that have visited City of Hope. And now that COVID is over, we hope more of you will visit. And there are also other pictures that I can't fit on here where we have visited their centers. And again, a wonderful experience, just sharing ideas, concepts, and experiences. And finally, of course, our patients. This is a picture of the annual get-together of our bone marrow transplant survivors. You can see it's a large group. As I mentioned, a large group of the subset of these patients have received radiation. Special thanks to this first patient who we were able to do planning with TMI and really get the program started and convinced our team and hematologists to proceed further into clinical trials. Her plans have kind of shown up on other textbooks. So this is a very popular image. And then this is the first patient treated, patient with multiple myeloma treated in June of 2005. She is still alive 18 years later. So again, thank you to her. So I'd like to thank you all for giving me the opportunity to share our experience with you. And I would be happy to answer any questions. Thank you so much.
Muchas gracias, doctor Wong, por su plática. Sin duda alguna de un gran nivel. Me pueden ayudar aquí en la traducción también para que el resto pueda estar escuchando las preguntas y respuestas. Sin duda alguna le comentaba de un gran nivel y admirados por todo este trabajo que han hecho. Y le platicábamos en la anécdota que nosotros tenemos aquí en México. Siempre hay un paciente que hace que los médicos cambiemos nuestra estrategia, que creamos que podemos hacer cosas diferentes. Y por supuesto en Monterrey una anécdota muy parecida a la que usted tuvo. Nos animamos a hacer trasplantes de médula y total marrow, total nodal ahora actualmente con la tecnología, pero empezamos con TBI, que es lo que más se practica en América Latina. Y siempre hay un paciente que nos impulsa. Y gracias por compartir también esta información. ¿Están ayudando a traducir? Perfecto. Nosotros somos un país que estamos en transición actualmente para el desarrollo también en el equipamiento y el desarrollo de nuevas tecnologías, implementación de nuevas tecnologías, perdón, en México. Y este tema nos pareció a la sociedad, a la mesa directiva actualmente, muy interesante, ya que es algo que probablemente ayudará a a enfermedades que son de alta incidencia como la leucemia, el mieloma, los linfomas, y en donde en Latinoamérica estamos en esa transición del uso de grandes cantidades de quimioterapia a largo plazo, de prendimientos de estos trasplantes no tan agradables, de infecciones y complicaciones infecciosas sobre todo a corto y mediano plazo. Y este tipo de propuestas nos ayudan como sociedad a tratar de implementar nuevas tecnologías, a equipar nuestros hospitales y animarnos a ser más ablativos. Es una reflexión que antes se la comentamos y creo que este tipo de ejemplos de que se puede, de que se logra, de que son exitosos los tratamientos en hemato y radioterapia, impulsan a las nuevas generaciones y también a las generaciones que ya tenemos un poco más de tiempo a intentar ser un agente de cambio en nuestro medio en este tema. Antes de ahondar en preguntas puntuales de su presentación, me quisiera ir un poco más para atrás, más hacia atrás en el conocimiento y decirle qué comentario nos puede hacer a un tipo a la sociedad latinoamericana de médicos que estamos en esta transición tecnológica para animarnos a hacer este tipo de procedimientos.
So I think the question is because I was listening it through the interpreter, what can we do? What would we do to encourage people to make this change? Is that the question? Yeah. Well, I want to share with you, I hope I was able to share with you that we also had to make that change. It did not happen overnight. It actually took 4 years on our end to convince our hematologists to make this change. It's probably not that long for people now that there's quite a bit of experience using this technique. I think the challenges are primarily in 2 areas. One, your hematologists need to be interested and need to be comfortable. If you are at a center where they have patients who are in relapse and they don't have good options, I think this is the population that they may be most interested in getting started. If you have physicians hematologists that because of the published results with IMRT TBI, they may also want to transition. The second challenge, or at least thing to take on is really it's just a change in workflow. I think if you're doing standard TBI, this shouldn't be too great a transition. You should be able to transition fairly smoothly. You already have a transplant program. You have hematologists that are interested in using radiation. So all the factors are set up for you and your team. I think it's more challenging if you don't have a transplant program, especially one without much allogeneic transplant. That may be more challenging. But still, I've seen programs be able to start from that beginning point or starting point. Hopefully that helps. I don't want to discourage people who want to get started and they haven't yet started allogeneic transplants. I do think that this approach is very encouraging. It can be a differentiator for the program. I think the basic message is you can't get started without your hematologist wanting to do this. It's challenging. People have tried just to do it without their buy-in, saying it's a better technique, but you really need the hematologist to be involved. So it's very important for whoever's doing this work, including ourselves. Hematologists go to the meetings to present their results to their colleagues. We're finding more and more interest in hematology and more traction in this area. So I hope I've answered your question.
Y gracias. ¿Quieren leer la pregunta que se hace en el chat?
Question I see is what would be the benefit of TBI conditioning compared to chemo-only conditioning in auto transplants for multiple myeloma? I can just speak for our particular experience. At the time our TMI trials in myeloma started, it was literally the first trial. These were in the mid-2000 period, at least in our country and at our center, as well as other centers in the US. They were interested in transplant. They were interested in using radiation as part of the transplant regimen. Since then, the interest has waned. It's really gone away. You're seeing that not only at our center, you're seeing it at the other centers that initially started with TMI. I don't know if you are anyone from the European group that did TMI initially. They were very interested, including hematologists. But options for multiple myeloma have changed. We're seeing it's not really that feasible to do a TMI trial anymore, at least at our center, because of all the other treatment options that exist. So if you can do it starting acute leukemia, that would probably be the best. It's another, I apologize, I don't speak Spanish, but there's something in Spanish that came up.
Sí, aquí en el chat están haciendo una pregunta del doctor, si me pueden traducir, del doctor Elías González, hematólogo. Dice, en México existe el problema de falta de acceso al trasplante, así como pocos hematólogos y radiooncólogos y unidades de trasplante pequeñas. Una de las estrategias para aumentar el flujo y cantidad de pacientes trasplantados ha sido la realización de trasplantes ambulatorios o estancias hospitalarias cortas. Pregunta que ¿cuál es el tiempo de prendimiento de las diferentes líneas celulares y la mediana de estancia hospitalaria en estos acondicionamientos?
Yeah, so let me just mention a couple things related to the question. We feel that the engraftment kinetics are very similar to standard regimens. we've seen no delayed engraftment. As I mentioned, we've seen no engraftment failures. So as a result, at our center, and we have tended to do transplants, including TBI regimens, standard TBI, all as inpatient, but they're all transferring to an outpatient setting. TMI remains inpatient because it's on protocol, but we feel, especially for that last regimen that was so well tolerated, that could go outpatient. And when we speak to people like yourselves, there are certain countries like Mexico, where much of the transplant is outpatient. We feel we have much to learn from you folks, your team and your transplant teams and your centers as to how best to coordinate outpatient conditioning. But we're moving in that direction. So I don't know if I answered your question specifically, but I just shared with you our experiences and thoughts at this moment as to outpatient conditioning. We feel TMI provides that opportunity, but we personally have not looked at that yet at our center.
Explayándome un poco en la pregunta que está haciendo el doctor Elías, nosotros precisamente no es solamente la dificultad en el equipamiento con aceleradores lineales de alta tecnología, sino también el acceso a quimioterapéuticos adecuados, a estancias hospitalarias con estándares de calidad adecuados para disminuir las infecciones. Y por eso, como América Latina, creo en México, América Latina, como un buen representante de esta maniobra terapéutica, sí, los trasplantes ambulatorios estamos intentando que sea empujando el conocimiento hacia allá para tratar de que se hagan, que se lleven a cabo, para tratar de librar también todas estas complicaciones de los pacientes que pueden estar crónicamente internados. Y eso aunado, no se diga más, también al aspecto económico, que también suele ser un problema para los pacientes aquí en México y en América Latina.
So there's a question, what is your experience with this technique in reduced intensity regimens? Thank you for the question. These are sort of my perspective when you think about it. When you change the dose distribution from standard myeloablative TBI to myeloablative TMI. Are you ready?
También en esta ponencia nos acompañan físicos. Y yo sé que usted comenta que no entraría en detalles técnicos, pero sí creo que son relevantes, dado que en esta mancuerna que hacemos con nuestros compañeros de física médica, nosotros proponemos un tratamiento mieloablativo o inmunomodulador, y sí es una variable a tomar cómo poderlo hacer. Los que hemos leído sus artículos sabemos que cómo han ido avanzando con técnicas de conformacional, con técnicas de tomoterapia, y ahora nos dice que con RapidArc por vía de variant. Entonces, creo, ¿qué opinión le merece el cambio en técnicas de radioterapia, y si eso altera los resultados de clínicos esperados, porque en México tenemos de diversos tipos de aceleradores. Hay quien pocos tienen tomoterapia, muchos más tienen acceso a conformacional 3D. Sí hay aceleradores para técnicas de BMAT o RapidArc. ¿Qué opinión nos puede decir si esta variación en la tecnología, en el tipo de técnicas, puede influir en los resultados clínicos de lo que ha reportado?
Yes, thank you for the question. Let me address that question, then maybe if there's time, I'll address the previous question. But as I mentioned, we also do VMAT, TMI. First, I don't know if there are variant representatives or accurate representatives online, but I will first, from a pure dosimetry perspective, the plans are comparable. I have a slide where we show the two plans and how the doses, the mean organ doses, they overlap. There should be no difference in efficacy or toxicities with the two techniques. The differences probably relate more to how much the workflow for each technology. Tomotherapy, you don't have the multiple isocenter and the extra time that it takes to use multiple isocenters. Those are some differences. But if you follow the established techniques now for BMAT, Electa or variant or Tomo, you'll have similar dosimetry. So not having tomotherapy still means you can get into doing total marrow irradiation. Other parts of the workflow, probably, some of it may be related to downtime, meaning, that may factor into some decisions. I think an exciting area, perhaps someone on this call may get interested, is there are at least one or two groups, including ourselves. We're about to demonstrate Halcyon or /ethos as a method. Potentially that could be better than our current TrueBeam 5 isocenter method. Again, I guess the bottom line or the main message is you should be able to also have a very active program using non-tomotherapy technology. We still use the tomotherapy primarily because of the lack. We don't need to do the multiple isocenters. But we feel the variant to also be involved in variant and Electa technologies is very important for this field because it's a larger install base and it may be the predominant user going forward. We'll have to see. Did you want me to address the reduced intensity regimen question? Okay. So actually, when you think about it, when you do dose sparing with TMI, you have a hybrid solution. You have full intensity to the target, reduced intensity to the rest of the body. So TMI in and of itself is a reduced intensity form of therapy. And when you think about it, yes, and our approach is to combine TMLI with fludarabine and melphalan. That's our standard reduced intensity regimen. Others have used fludarabine busulfan, as I mentioned. We have another protocol that looks at fludarabine cyclophosphamide. But mainly our main interest has been fludarabine melphalan. Dozens of patients treated. I showed you don't know if you recall, TMLI, 12 gray, fludarabine, melphalan, with a 40% overall survival rate. That is actually a regimen where our hematologists no longer want a protocol. They want to establish that as our institutional standard of care for patients who are older, who cannot get into remission. And we're about to make that transition. So our institution is moving away from protocols to just making it standard for certain populations. I hope that answers your question.
Aquí también hay una pregunta, si nos permiten, de la doctora Yael Cázares, que felicita al doctor Jeffrey Wong por su ponencia. Y su pregunta es, para pacientes con LLA, con leucemia linfoblástica aguda, que recibieron radiación previa a holocráneo o cráneo raquis, ¿qué ajuste en la dosis y volumen de tratamiento para irradiación medular total sugiere realizar?
I missed that part of the question with cranial CSF involvement. Is that the question?
Que son pacientes con LLA que ya se habían tratado previamente con un tratamiento holocraneal o craneoespinal. Y después tienen la necesidad de un trasplante con acondicionamiento con irradiación medular total.
That's a very good question. We don't see a lot of those patients. What we have done on rare occasions is, especially if the craniospinal dose isn't too high, we've added a myeloablative dose of TMI on top of that, or not on top of it, but after, if they relapse, we would take them through an allo transplant with a reduced dose of TMI. And I think we're familiar enough, everyone, as to how much cumulative dose you could probably get away with. This comes up, it's coming up more and more often as people, your hematologists, get more and more familiar with the capabilities of the technology. Yes, with previous craniospinal, many times there's no radiation involved, and sometimes we're asked to look closely at a patient off of protocol with a reduced dose of TMI. Patient just this morning, somewhat similar in theory, 2 failed transplants, 2 gray each time. So that's previous 4 gray TBI, but now relapsed, and they want radiation containing regimen because they can't get that patient to remission. So, we're doing a reduced TMI with cyclophosphamide in this particular patient. We don't have a standard approach because it's infrequent, and you have to kind of use the available information and see if you can add a certain amount of dose on top of what's been previously irradiated. And I think the technology allows you a lot of control as to where the dose can be targeted and where the dose can be spared.
There is another question in the chat.
Yeah, somewhat similar to the last, I guess, answer that our current trials, as you already saw, have a mix of populations, and patient with relapse disease after with CNS relapse is unlikely to get on those trials. So we just don't have enough numbers to really answer that specific question. You know, there is some interest in focusing just more on AML and having a separate trial for ALL, but I just don't have that answer for you because it's an infrequent use of TMI at our institution.
¿Hay tiempo para más preguntas, administración?
Parece que ya no hay más preguntas, doctor.
Okay. Thank you, Professor Wong, for your presentation.
Thank you very much. And thank you everybody for staying so late to listen to this. Thank you so much. I hope I see people at the meetings, and please feel free to visit if you're in our area.
Muchas gracias. Agradecemos al doctor Eric Edmundo Pérez, agradecemos al doctor Jeffrey Wong por su participación. El día de hoy tuvimos más de 230 participantes, la mayoría egresados, 88%, 186 médicos radiooncólogos, físicos médicos, técnicos, otro personal de salud, la mayor parte del centro de la República, el 34%, seguido del noroeste, el occidente, y tuvimos 10 de Latinoamérica y Sudamérica, y de otro país también 4 participantes. Como anuncios para nuestros socios de Somera, el próximo 10 de agosto será la sesión de residentes, tratamiento actual de cáncer cervicuterino con técnicas modernas de tratamiento, presentada por el Hospital Regional Centenario de la Revolución Mexicana ISSSTE de Morelos, y a la par se realizará el concurso para ser acreedor a un pase doble VIP para el concierto de Taylor Swift. Los invitamos a comprar sus boletos. Recuerden que incluye el vuelo, el hospedaje para las personas que se encuentren en el interior de la República, y los fondos se destinarán para diversos proyectos educativos. Asimismo, tendremos una sesión general el 24 de agosto con el tema Abordaje y manejo de la dermatitis inducida por radiación, a cargo de expertos nacionales del tema. Y bueno, para aquellos interesados en participar en el programa de Space de Twitter de Somera, un espacio por radiooncólogos mexicanos y destinados para brindar información a pacientes y población general, les agradecemos que envíen sus datos para organizar fechas y temas para su próximo lanzamiento. Al teléfono oficial de Somera, que se los recordamos, es 55 18 27 83 70. Y bueno, muchísimas gracias nuevamente al ponente, al coordinador y a todos los participantes. Gracias y buena noche.
Gracias, buenas noches a todos.
Thank you.
Thank you very much.
Thank you so much for keeping in touch. Okay. Bye.
Bye-bye.
Thank you.